and thanks for organizing this meeting. Let's go into the case. Next slide, please. All right, thank you. Well, we had to take care of a 20-year-old female who presented to our ER with epigastric pain, nausea, vomiting, fatigue, and subfebrile temperatures for the last 4 days. She was, except for Hodgkin's lymphoma, which was treated by chemotherapy years ago, she was a completely healthy young lady. And you can see the initial labs that are fairly uneventful. There is no real sign of infection. And I have put on this by purpose. All the renal parameters were fairly normal. Now, she was admitted to the hospital because she was not really doing well. And 30 hours after admission, I have put down the labs she had by then. And you can see a deterioration of renal function as well as fairly high lipase, LDH, and bilirubin values. Now, in a ultrasound and CT findings, we had evidence of severe cholecystitis with gallstones and pancreatitis as well as ascites. There was at that time no sign of a dilation of the bile ducts. Next slide, please. So what was the diagnosis? Now, the things that are we actually did the diagnosis of acute abdomen due to biliary pancreatitis and cholecystitis. And that was, by that time, to our impression, already accompanied by renal deterioration. So what was our approach? Next slide, please. We, next slide, please. We performed a laparoscopic cholecystectomy in her. Now let's go just a little sidestep to the mortality of acute pancreatitis. If it is not severe, it's typically not really high, but if you have a severe case of acute pancreatitis with an Apache 2 score of greater than 10, and I'm going to show you the score of this young lady, it is fairly high. It is around 40%, and most likely this is due to all the systemic inflammation that is going on with consecutive organ failure, and that was exactly the picture that was presenting to us. Next slide, please. Not really surprising, in severe acute pancreatitis, cytokine absorption was already published in a case series from Romania, where the colleagues from there presented 12 cases. And in all of these cases, patients were weaned off vasopressors fairly quickly, and the lab values were normalizing fairly fast with the with cytokine absorption. Next slide, please. And consecutively, there's a larger prospective study that was initiated by the colleagues from the University of Munich that is dealing actually with the exact same question. Next slide. When the lady came to our intensive care unit after the operation, the initial Apache 2 score was 15. So she was in that range where the mortality of pancreatitis in itself was fairly high. So despite differentiated fluid therapy, antibiotic treatment, in the next hours after surgery, we saw a further decline in renal function. I have shown you the creatinine and uric acid values here. And now the infection parameters were rising. The CRP, PCT values were indicating a septic condition. Further, the global coagulation seemed to be impaired as well. Next slide. So what we did is we initiated renal replacement therapy and included cytokine adsorption. Next slide, thank you. As you can see here in the lower part of the picture, and it is unfortunately in German, we used over 72 hours, 5 filters in the initial course because she appeared very sick, although she never was on vasopressors, and in order to get rid of all the cytokines. Next slide, please. Here you can see the CRP values before and then after 12, 24, 48, and 72 hours after initiation of cytokine adsorption. Next slide would be the PCT values that normalized under the treatment. Next slide, and bilirubin. Next slide, please. Bilirubin, and this is actually a phenomenon that we know very well as well. Bilirubin is absorbed by the cytokine, by CytoSorb very nicely. And next slide, lipase values were normal after 72 hours as well. So at this point, you would think, well, great solution, everything is fine. But next slide. What was really noticeable was, except for the recovery of renal function after 4 days, that we had persistent thrombocytopenia, around 40 to 60,000 cells per nanoliter, and an anemia with the lowest value of 4.9 hemoglobin without any significant bleeding. Now, at that point, we went deeper into the case and revealed the presence of fragmentocytes, a reduced haptoglobin, and reduced ADAMTS13 activity. Next slide, please. And this brought us to a further diagnosis of thrombotic thrombocytopenic purpura triggered by severe acute biliary pancreatitis. Next slide. At this point, we switched to plasmapheresis as the standard therapy of TTP and combined it with corticoid therapy. Next slide. Let's have a quick look into the thrombotic microangiopathies. They always go along with thrombocytopenia and anemia due to the shear stress, and then they eventually lead to end organ dysfunction due to generalized microvascular occlusion. And next slide, please. This is this entity of thrombotic microangiopathies is divided into TTP, which is actually characterized by the deficiency of the ADAMTS, and I have written down what it really means, due to autoantibodies in the acquired version of the disease. And this really has an untreated mortality of up to 95%, so real bad. Next slide. And the other big entity would be hemolytic uremic syndromes, where the typical form is associated with the Shiga toxin of Escherichia coli, and the atypical form would be a complement activation. Now, here you would not see a reduction in ADAMTS13. Now, keep in mind that the TTP is triggered by autoantibodies that lead to a deficiency of ADAMTS13. Next slide, please. The further course was that we saw a total recovery of platelets and hemoglobin after 3 cycles of plasmapheresis, which is fairly fast. And unfortunately, the lady recovered completely, was discharged from our ICU after 9 days, and home in good medical condition after 24 days of treatment. Next slide, and that would already be my last slide. So in conclusion, we had a complex case of TTP associated with severe pancreatitis, which in itself has the pancreatitis plus TTP has a real high mortality without adequate treatment. And cytokine adsorption was initiated for the inflammatory response due to pancreatitis, and the idea that this would be a septic case, which we would routinely treat with cytokine adsorption. Now, the potential benefit for the TTP was probably the elimination of autoantibodies, which explains why we got along so fast with the treatment of TTP. Now, I hope I could make up some seconds at least. Next slide and last slide. Thank you for your attention.